You also can do what is called image-guided endoscopic interventricular tumors. And these are for things like pineal region tumors, colloid cysts, arachnoid cysts, craniopharyngiomas, and dermoids, tumors that are in the center of the brain sitting in the ventricles. It's a very difficult area to get to, but what we use is what's called a brain port. And so in the old days, what you would do is you'd make a big incision in the head, you'd open up the brain, you actually cut part of the brain, retract part of the brain to get to the middle of the brain to get to the tumor. Nowadays, what we're using is this neuronavigation, that GPS system. We're lining a specific trajectory to get down to where this area is, and we're using these little tubes. They're called brain ports. This is one of them right here. And we advance this right down into the brain, and then we operate through this port. The port displaces the brain tissue like jello, and then once you take the port out, the brain comes back together. It doesn't cause really any damage to the brain at all. And then we use an endoscope through that little port to remove the tumor. So here's the port. They're pretty small. This is basically what we would expose with. The incision's about this big. Here's the opening in the brain, about 1 inch. Here's an example of what it looks like. This is a pretty short video. So this patient had what's called a colloid cyst. They'd had the cyst removed at the University of Miami about 15 years ago. It came back. This patient actually showed up into our hospital in a coma from hydrocephalus. And one of the things with colloid cysts is they are known to cause sudden death. People who are awake 1 minute and dead the next, because these tumors obstruct their ventricles, they develop acute hydrocephalus and die. So this patient was trying to do that. And so we diverted the spinal fluid. This is the port that we have in there in the brain. We're about that far into the head. And here's the colloid cyst. And so we opened it up. We're now removing the contents on the inside of it using a suction device. We're now opening the hole that communicates the lateral ventricle to the third ventricle, so there's no longer a pressure issue. This patient has a very important vein right here. That's a septal vein, and if you injure that, you basically give them what's called a fugue state for the rest of their life. They're not going to have any memory. So it's a pretty important blood vessel, so we have to be pretty careful with it. And now we're removing the capsule of the tumor, because if you don't remove that capsule, this is just going to grow back. This whole surgery takes maybe an hour. Okay. So again, we use coagulation devices to kind of help separate it away from the blood vessel. The tips of those devices, those coagulation tools, they're about 1 or 2 millimeters in size to kind of put in perspective what we're dealing with. And so now the tumor is out. This is actually choroid plexus in the ventricle. We're looking around. We're adjusting the tube a little bit to make sure we don't see any bleeding. It looks good. And then basically we remove the tube. The blood loss from this surgery is about 5 milliliters. So it's really minimal. So you take the tube out. You can get a perspective for how deep we are here when it comes out. We look at the walls of the brain as we're taking it out to make sure we didn't stir up any bleeding. And you can kind of see that was a pretty deep hole. And then now we're done. And you have an MRI, and you cannot even see a trajectory where the tube was placed. The brain just came right back together. Tumor's gone. Patient did well. You can also use this for pineal region tumors. Using that same device, you can stick a needle back there and biopsy these tumors and remove them in the same manner. Most of the time we biopsy those tumors. We do what's called a third ventriculostomy to kind of relieve the pressure from the spinal fluid. And then we wait for a pathological diagnosis. And if it's the kind of tumor that actually needs surgery, then we go back in to resect it. If it's something that you can just treat with radiation or chemotherapy or gamma knife, then we otherwise do that, because there's a lot of risk in operating in the pineal region, so we try to avoid it when we can. So you can treat all kinds of interventricular tumors there, obstructive hydrocephalus, and there are some people who are even toying with the idea of whether you can use these ports now with an endoscope to remove intraparenchymal masses, like a brain metastasis or a glioma. And there are a couple of people around the country that are playing around with it, but no one as of yet who's actually said that's a benefit. So you want to make sure that, you know, the old saying, a fool with a tool is still a fool. You want to make sure that you're actually using it for the right purpose. And then finally, I just want to mention gamma knife briefly. So gamma knife is another minimally invasive tool that we use to treat brain tumors and brain lesions. It's actually not surgery at all, but it's a form of radiation that we can use. It's outpatient. and it works as precise as using as a scalpel. That's why we call it the Gamma knife. The Gamma knife is an 1,800 kilogram basically machine. It uses a cobalt radiation source, and it has 201 channels, or essentially rays, that focus onto one point, that point being whatever you want to treat, to zap tumors, if you will. The accuracy of the Gamma knife is 0.3 millimeters. So you kind of aim this laser of radiation, if you will, at a tumor, and 0.3 millimeters away, there's virtually no radiation. So it is very precise, and it treats probably 90% of all brain tumors you can treat with Gamma knife, and it will prevent those tumors from ever growing again. It's extremely effective. However, it can only be done for lesions that are less than 3 centimeters in size. Okay? It doesn't treat other areas of the brain. So if you have someone with cancer and has 8 lesions in the head, you probably can't treat all 8 lesions with Gamma knife. It's too much of the brain to be involved. It's extremely potent. It's analogous to using a magnifying glass in the sun in the summertime at a blade of grass. It'll burn whatever it's aimed at. And that's what the Gamma knife does. But it's a fantastic option because it does not involve any kind of sedation. It does not involve any kind of surgery. People can be on Coumadin and blood thinners and get Gamma knife. They can be getting chemotherapy and getting Gamma knife. So people who aren't surgical candidates, this is a great option for them. Since 1996, the first Gamma knife, by the way, was here in Orlando in the state of Florida. And they've done over 2,000 patients here in Orlando already. So they have one of the largest experiences in the country. The goal of the Gamma knife is to stop the tumors from growing. In many cases, not only does it stop it from growing, they actually will shrink. It eliminates the risk for surgery. It maintains neurologic function and improves patient symptoms. The typical day for Gamma knife is that the patient shows up to the hospital at 6 in the morning. We put this frame on their head at around 7. They then go for an MRI. Once the MRI is done, we play on the computer and basically tell the machine where they need to aim the Gamma knife. They then sit in the Gamma knife anywhere from 10 to 90 minutes. And then the treatment is done. We take the frame off that we put on their head, we get them some breakfast, and they're home by lunch. We actually have patients who will be playing golf that afternoon after a Gamma knife. It's that benign of a process. Dr. Baylor, this one's for you. This is a 95-year-old guy who had an acoustic neuroma. He was found to have the acoustic neuroma when he was 94 years old. And his son, who is a neurosurgeon, said, "Dad, we're going to leave it alone." Wise thing to do. Well, in 1 year, it doubled in size. The patient was starting to have more balance problems and ringing in his ears, and the son wanted it treated. He said the patient's symptoms are intolerable, it's grown in size. This guy was 95, but looked 70. I mean, he really was a very healthy man, and it kind of goes with the theory that you don't get to live to 95 by being unhealthy. He was a perfect specimen, quite honestly. He took 1 medicine a day, okay? It was a baby aspirin. So very healthy. So they came to us and they wanted Gamma knife. Now the son's a neurosurgeon. He's fully aware of what needs to be done. And so we said, okay. This is a very small lesion. Here the guy is in the bottom right-hand corner. He had the frame put on his head. Here we are. This is the plan that we do where we tell the machine to aim the Gamma knife at this location and not anywhere around it. And we know that for acoustic neuromas that if they're under 2 centimeters in size, and you do Gamma knife for it using a dose of what we call 12 gray, there's a 94% chance that at 10 years the tumor will not have grown at all. So it's pretty effective. And the complication rate of it, about 50% of people, if they've not already lost their hearing, will progress to lose their hearing. And the risk of them having a facial paralysis is less than 1%. They don't have the risk of bleeding or infection. They don't have to recover from surgery. So it's pretty good. And so for all of our small tumors, although we could very easily remove something like that with an endoscope, we'd rather use the Gamma knife.